Okay, start with introductions. It's at 3:02 already. So welcome to the Timid Seminar Series. Today, the Population Informatics Lab has invited Dr. Abeed Sarker, who will be talking about social media mining for substance use research. He is an associate professor and the vice chair for research at the Department of Biomedical Informatics at the School of Medicine at Emory University. He leads several large-scale projects focusing on the application of natural language processing for health-related tasks, particularly those involving vulnerable populations such as people with substance use disorder, victims of intimate partner violence, and people at risk of self-harm and suicide. His research is primarily funded by the National Institute of Health and the CDC. Thank you for coming.
Oh, thank you. Thank you for the very kind introduction. So yes, I'm an associate professor of the Department of Biomedical Informatics. My background is computer science, specifically computational linguistics. So for my PhD, I was looking at automatic text summarization for evidence-based medicine. Back then, summarization was a difficult problem. I mean, it's still a difficult problem, but then we didn't really make much progress. Summarization is much more of a solvable problem nowadays with generative AI models and stuff like that. Anyways, so being in biomedical informatics, so my research lies very much at the intersection of natural language processing, applied machine learning, and public health and medicine. Specifically, I am interested in building or designing, developing and deploying sort of end-to-end NLP pipelines that can convert big, often noisy, often small text-based data into like valuable and actionable knowledge that can be used by domain experts. Right, I work with text-based data from various sources. So there is electronic health records or clinical notes. We work with published literature, which is another source of text-based data, and a chunk of my work focuses on social media data. So in today's talk, I will primarily focus on the social media stuff. Specifically, a substantial portion of my work focuses on substance use and substance use disorder and sort of NLP applications in that space. I will focus mostly on the application and sort of how we move from sort of an overarching idea to solving targeted problems applying NLP and machine learning within the substance use field. So some of the, before I dive into a little more detail on the specific problem of substance use, I just wanted to sort of rehash all of the types of topics I am working on. So my broad objective is to work on NLP for social good, and consequently, like I address a lot of social problems, also public health problems using NLP. Today's topic will be substance use and substance use disorder. I work a lot on violence prevention, specifically suicide, also some homicide data analysis and intimate partner violence, both from clinical sources of information and also social media. We have started working on social isolation and loneliness, specifically their impact on aging population and on suicide and problems of that nature, which appears to be a growing problem in the United States. And of course, like one of the things that we can do using social media or some other data sources is do research on underrepresented populations or people who are often ignored or excluded in traditional research. And also, like one of the interests I have is working with data from low and middle income countries, specifically with the emergence of large language models. What happens is large language models are very, I would say, Eurocentric in their training data. And as a result, they don't generalize well with data from low and middle income countries, especially when it comes to deployment. There are also like cultural congruency issues. So LLMs may be able to generate text, but they may not be culturally congruent with social norms and things like that. For example, we have a chatbot that we are trying to implement for maternal health related support in Nigeria. And that's where I'm learning a lot about, okay, what are the, like, it can be like pregnancy can be a sensitive topic in certain parts of the world. So maternal health, in fact, it can also be a sensitive topic where people may not very openly talk about maternal health. So how does an AI chatbot take, like, sort of incorporate all the cultural norms and talk in a manner that is culturally acceptable and not unacceptable? Anyway, so that's an overview of the types of work I do. Most of it is like from NIH or CDC or some other funding source. But today I will talk a lot about, or my entire presentation will be on substance use disorder, especially in the US context. So before I get into the methods and our processing pipeline, I wanted to give an overview because most of you are probably not familiar with the problem of substance use in the US. So this figure shows the state of substance-related overdose deaths in the United States. So for those who are not aware, there are over like 100,000 deaths that happen every year from over the last few years. From substance-related overdoses, which means that there are about approximately 300 deaths per day, which is fairly alarming, right? These deaths are caused mostly by opioids, but opioids are not the only things. They can be caused by benzodiazepines, by polysubstance use, and so on and so forth. One of the things is that as you can see, like the main thing is that, so there was a Nature article a few years ago which showed that the trend of substance-related overdose deaths is consistently increasing. It's just that the underlying substance that causes the majority of deaths changes over time. So early 2000s, it was crack cocaine, then came prescription opioids due to like this push from the pharmaceutical industry to like give everyone opioids. Then came heroin, then came fentanyl, and now we are seeing a fourth wave with weird substances like xylazine, animal tranquilizers, all contaminating the opioid supply. And apparently, according to the CDC, in fact, there is no heroin in the heroin supply anymore. It's all fentanyl and other types of opioids. Another alarming thing here, so this, of course, the number of deaths and increasing thing is pretty alarming. Another interesting thing here, so this is the latest final data that we have, or latest confirmed data. What we can see here is in the x-axis, the latest year we have is 2020, like 2022. And we are almost at the end of 2024, right? So there is a substantial lag in the manner in which these numbers are collected. So overdose death reporting, to collect and curate all the numbers, it has a lag of about 1.5 years. Same with survey-based mechanisms. There's the National Survey of Drug Use and Health, which takes over 1 year to compile. And so imagine for a problem that is fast evolving, knowing that the number of deaths 1.5 years after they have happened is not that useful, because that doesn't really help us create intervention strategies or come up with intervention strategies, because by the time we know the overdose death numbers, the problem has already shifted, right? There are probably other substances that we are not aware of that are entering the market. So I will come back to that a little later. Let me give you a little bit of a little more overview of the problem. So some of the things we see, as I mentioned, opioids are the primary cause, like of overdose deaths, over 80,000 deaths, but then there are other substances that are also involved, and then we don't really know the extent to which they're involved, primarily because unless there's some toxicology testing, we don't really know if a certain substance was present in someone who died or not. So opioid testing is done very regularly. However, something like benzodiazepine would not be tested very regularly. So, but they all contribute. So stimulants involve, for example, cocaine, methamphetamine, and other psychostimulants. They are also alarming, increasing in terms of overdose deaths. There are also antidepressants that are involved in with opioid involvement. So polysubstance use is a big problem because taking multiple substances can substantially increase your chances of overdose. So with the growing problem of substance use and substance-related overdose deaths and the limitations we have in surveillance, specifically this lag, there is a strong motivation to identify newer and more innovative sources of surveillance that can complement these traditional sources. And social media is a potentially fantastic resource. It may allow us to study substance use in near real time, so we can mine social media data close to real time. We can do it without we can do it unobtrusively, so we don't have to intervene in people's lives to actually get social media based estimates. And we can do it at scale. We can essentially use the entirety of Reddit data, which is what we do. How many of you are familiar with Reddit? Oh, most of you, that's great. Not all of you. So yes, so we use Reddit data a lot. Reddit is heavily moderated. We have the whole of Reddit in our database up until the beginning of 2024. So because there were some API changes in 2024. Anyway, so why social media then? Of all the different data sources, why do we want to use social media to study substance use or anything? And the answer is pretty straightforward. Social media has social media adoption is at an all-time high now, right? More people are using social media than ever before. And in fact, now with some social networks like Facebook sort of hanging as being there for a long time, we also get different populations on different social networks. So in fact, we are doing a study on Parkinson's where we're actually recruiting Parkinson's patients and obtaining their social media by consent. And all of them have Facebook data. And of course, Parkinson's population is an older population and all of them have Facebook. So we, in the past, we used to say that social media is primarily for younger people. That is not the case anymore. Now, you just have to know which social media. If you're trying to study a bunch of adolescents using Facebook data, you will not get anything because kids these days don't use Facebook anymore. In fact, even grown-ups have stopped using Facebook a lot. Me, my mom is always on Facebook, so I barely use it. So I've moved to, so yeah. Anyway, so it covers a wide range of population. Over 4.5 billion people in the world use social networks. So it really gives us access to a large amount of data that we can analyze. Does it have its biases? Yes, of course. Any data source has it. There's no data source without any biases. Can social media data replace traditional mechanisms? Possibly, but that is not our intent. What we are trying to do is show that it can complement traditional sources, providing another perspective and so on and so forth. So yeah, as you can see, YouTube is considered to be a social network now as well. So YouTube seems to have the highest adoption, although we don't use YouTube data in our work. Reddit is one of the smaller ones, but Reddit is specifically useful for substance use related research because Reddit is anonymous, right? Or it's built on the concept of anonymity, so a lot of people feel very comfortable sharing very sensitive topics on Reddit. So this is the question I get every time. Whenever I tell people that I study, so yeah, when people ask me what I do for work, my one-liner is generally I look at drugs on the internet, which is exactly what I do, right? And so then a common question that I get is, do people actually talk about this stuff on social media? And that sounds like for those who are not familiar with social media or have never looked at Reddit, it may look really like a crazy idea that people are openly talking about drug use on social media. The answer is yes, they're talking about it a lot. In fact, the way I came up with the idea of studying social media or studying substance use over social media was because I saw a bunch of drug-related posts way back when I was analyzing some data. So people share experiences, they share self-management strategies a lot, which is actually something that is very common in the substance use community, especially those who are recovering. They really use social media to share what has worked for them and what has not worked for them. They also support each other, often anonymously. You don't really need to know who the other person is on social media to be able to provide them some support. So, and much of the data is publicly available. And I wanted to give you some examples. So fentanyl withdrawal help. So here a person is asking about, so my sister-in-law and her husband flew in last night, they have been hooked on various drugs. So asking about some specific question about fentanyl withdrawal. Fentanyl is a type of opioid, it's a short-acting opioid, but then it has some weird mechanisms of action, I think. I'm not a doctor, so I have some thoughts, but I will not say them because I don't know. Suboxone microdosing. Suboxone is a treatment for opioid use disorder. And people on Reddit have figured out strategies to microdose. Remember this microdose term because we will come back to it later. And I will provide an example of a case where we learn from social media and teach medical experts. But yeah, so they're talking about how to microdose Suboxone to treat their opioid use disorder. How I use my chemistry training to quit benzos. So benzodiazepines are drugs like Xanax or Klonopin or tranquilizers basically. So, and then they can be very addictive as well. And yes, people talk a lot about how they have overcome their addiction or how they have fought to overcome their addiction on social media. And another thing that is, I think, very helpful on social media is people also do a lot of safety check where they are about to recreationally use some drug and then they ask others that, hey, I'm thinking about taking this much of this drug or this much of this drug, do you think it's safe? And then of course, if it's not safe, people will tell them like, hey, don't do this, you're gonna die or something. Which, I mean, it sounds very bizarre, but it's actually very, it's like pill testing, you know, at concerts, they do, like in some places, they do pill testing. Did you know that? Do you know? Like they test pills to see if they're okay or not. And then that saves lives, right? So this probably saves lives as well. But the question is, then can we derive these, like, can we leverage this huge source of knowledge and use it for our work? Yes, and also a lot of people think, those who are not familiar or have never worked with social media, they often think that social media is this big homogeneous sphere where all the data looks the same. That is not the case at all. Social media, depending on which social network you're working with, the data can vary substantially. Like Twitter is a very different resource than Reddit. Twitter is person-centric, where people are promoting themselves. Twitter may have geolocation. It is more, people are identifiable on Twitter, like on Twitter, I use my real name. I also use my real name on Reddit, and things like that. And then we can also collect peripheral information, like we can collect a lot of metadata. In contrast, so Twitter has a lot of application in like broader public health surveillance type space. Reddit is anonymous, it's topic centric, not person centric. So discussions are organized by topics. And the discussions are very candid because they're anonymous. And application is mostly medicine. So then the question is, if social media has this much knowledge, like this much information or data or knowledge about the topic, why have we not been using it forever? Like social media has been around for a while, but why aren't we using it in medical and public health research? And the answer is that social media text presents a lot of challenges. So processing social media text is more challenging than, let's say, domain independent text like news text. And then it gets even more challenging when you're working with social media based health related text, because you also have to take into account domain specific terminologies and concepts. And on top of that, social media based misspellings, colloquial language, evolving language, noise, data access changes. So Twitter, for example, recently changed their data access policies by last year, and that caused a lot of problems. So when you're working with social media data, you have to take into account all of these. And over the last few years, we have been slowly overcoming one challenge after another, to the point that now we are able to actually use social media to derive insights by deploying these end-to-end data processing pipelines for filtering data, characterizing data, and so on and so forth. So I wanted to give you a simplified sort of workflow of our social media mining pipeline, which we have built over 6 years now. So a common strategy to do social media based research is where you just go collect some data using keywords, and then you run your unsupervised models or whatever analysis you want on that data, right? So for example, if I wanted to work with opioids, I would just use some opioid keywords like OxyContin, Percocet, whatever, collect data and then analyze all of that data, right? When we did that, we found some problems. So number one, we found that data collection itself can be a problem because when we are using keyword-based data collection, we are often missing out on the misspellings that people use. So some drugs like Seroquel, or no one knows how to spell them. And then so as a result, if you're not incorporating the misspellings, then we can be missing out on a chunk of the data. So that's the first problem. The second problem is if you're working with opioids, then let's say if you search OxyContin on Twitter, you will see that most of the posts are talking about some news article or some celebrity death or something like that. And a very tiny portion, you'll have to go through a few hundred to find a few examples of where people are talking about their own consumption or their own non-medical use. And that is the part we are interested in. So we don't only collect data. After collecting data, what we do is we annotated a large sample manually to specify if their consumption, so consumption and non-medical use can be different things. Consumption, if someone says, I took my Adderall in the morning, that does not mean that they're non-medically using Adderall, because Adderall is a prescription drug, right? So they might be prescribed Adderall. However, if someone says, I bought 5 Adderalls with some coffee and all of that, which is things that people say, that then we know that it's non-medical use, right? So we have a supervised classifier that basically classifies each post into these categories, and only the non-medical, like a tiny portion of them represent non-medical use, right? Non-medical use means, like, another term for non-medical use is abuse, so drug abuse, but we don't use the term abuse anymore just because it's a stigmatizing term, right? So we use the term non-medical use. Anyway, so a tiny portion is non-medical use, but then what we do is, once we have detected that someone is engaged in non-medical use or someone self-reports non-medical use, and that data is public, we can actually collect that person's past data and future, like we can use the API to collect their past data, anything that they've posted publicly in the past. And then every 2 weeks or every month, we can collect their anything new that they've posted. And as a result, what we get are these essentially longitudinal timelines of Twitter subscribers or Reddit subscribers. And so, and it's continuous because it's the machine learning model is continuously detecting non-medical use. As soon as it's detecting, it's putting them in our database, and then we're collecting data periodically. In that way, we have collected over 600,000 cohort members of people who have at some point disclosed non-medical use. So it's a massive data set, over 3.5 billion posts. And then using these longitudinal timelines, we can do very targeted analysis, like age group analysis, race analysis, and so on and so forth. So I will now try to quickly outline the sort of these methods in these, and then provide an outline of some of our findings, and hopefully we still have some time for questions. So how did we solve the data, the misspelling generation problem? See, misspelling generation is sort of the opposite of spelling correction, but spelling correction is what I would say is a well-defined problem, because in spelling correction, you're taking an out of vocabulary word, mapping it to something that is in vocabulary, right? However, the opposite, when you have the correctly spelled word, and then you have to generate misspellings, how many misspellings do you generate? The combination of possible misspellings is somewhat infinite, right? Like you can keep on just generating combinations until. So one of the strategies we use is those of you who are familiar with word2vec. We learn these word sort of vector representations using word2vec from text. And we know that words that appear in similar contexts appear close together in vector space, right? And misspellings of drug names like clonipin and clonopin, these are misspellings, but then they appear in the same context as the correct spellings themselves, and as a result, they will have similar vector representations, right? And then after that, we first generate a set of possible candidates of misspellings from this, and then we just use a lexical similarity filter to filter out everything that's lexically dissimilar, right? And that's such a simple and elegant mechanism of generating misspellings and it's data-driven misspellings. It's not like misspellings that are never used. So these are any word that'll be captured are words that are frequently used in and so that's how we solve the misspelling generation problem. Any questions or thoughts? It's a fairly straightforward approach. Again, it's taking from NLP research progress directly to application and figuring out how NLP can help in achieving what we want to achieve. Supervised classification. So supervised classification is the next step. After we collect the data, then the objective is to be able to identify those that mention non-medical use. Yes.
Could you go over what kind of attributes we see on the data?
What kind of
Attributes, rows, columns. Like, what are the features that you're looking at?
So for the text classification, it's all text. So just the texts of the posts.
Okay.
So we are not using any structured data. So it's all we are just vectorizing the texts, and then I mean we have manually labeled them. So then just modeling it as a text classification problem.
Okay, and you mentioned 3.5 billion rows, right? How are you handling that amount of data?
3.5 billion posts, yes. How are we handling that kind of data?
I think you said rows, right?
Posts. So 3.5 billion posts. So we have now, I think we have more. We have like over 4 or 5. We don't process them in one go. They're all in our database. I mean, we have the whole of Reddit in our database as well, as I mentioned. So we don't process all of them put them in one table, and then we just extract out whatever elements we need, and then we So yeah, of course, the main part in so I believe that, in fact, a lot of people believe that instead of taking a large set of data and doing some unsupervised analysis, it always pays to actually do some manual annotation and take a supervised approach. And because this classification is such a critical step, we actually spent 1 year annotating over 16,000 Twitter posts. Each of them were triple annotated, actually. And then we trained supervised machine learning models. So supervised machine learning is a little boring these days, so not much to mention here, but way back at the beginning, we were using support vector machines with weighting. As the state of the art changed, we started using more encoder-only models like BERT and Roberta. And now we are finding even better results, where we actually recently completed a study where we are using a simple generative LLM to generate synthetic examples from the annotated examples that we have. And I mean, not too surprisingly, a few set of synthetic examples seems to improve performance substantially. So in our deployment, and like, because it's a continuously running pipeline, any method that gives us a performance improvement of, if it gives a performance improvement of 0.1%, then that's fit for a computer science publication, but it doesn't really help anything in the practical pipeline. But then if we get a 2 or 3% improvement, then we are like, okay, let's plug in this module. So those are the steps. And then I wanted to also give you an idea of more of the finding side as to like what we are finding. So one of the attractions to social media based data, especially from Twitter, is that we can actually, once we have done this supervised classification of non-medical use, we can actually map these to specific geolocation. Not everyone will have geolocation information, but because of the massive size of the data, a large chunk will be. And so what we wanted to see was, can we map these to specific geolocations? And then if we do, are these correlated with overdose deaths? Because the intuition is that if people are self-reporting non-medical use more in a certain location, it's more likely that there will be more overdose deaths in that location, right? We are not the first ones to try to use social media for this. There have been others, but then those studies have primarily showed weak correlations. We improved a little bit. So first of all, characteristics of Twitter data. Does anyone know what these two high concentration areas are? This is Pennsylvania, right? They're Philadelphia, so this is Philly and this is Pittsburgh. So there is like a high concentration of posts from citizens, even when we adjust for population, so we do adjust for population, but even then there is a lot. And what we found was, we found moderate but significant correlation between overdose deaths and also county level self-reported non-medical use. So this obviously gives us, was very promising, because that means that we can potentially predict county level deaths or estimate county level deaths using social media data, which is what we are doing right now. We are integrating this into a dashboard. We also found very good correlation with the National Survey on Drug Use and Health, or some metrics with the National Survey on Drug Use and Health, but since we were only using Pennsylvania as our target state and the metrics are derived at the sub-state level, we didn't have sufficient N to obtain statistical significance. So talking about, our geolocation-based stuff gave us like very promising results that we can potentially predict location-specific substance use. And that is what we are integrating into a dashboard now, where people can go and download the statistics. Another mechanism of collecting data, as I mentioned earlier, is the National Survey on Drug Use and Health. Now, survey-based measures have some advantages. One of the advantages is that in social media data, we can get some broad brush estimates, but then we cannot get things like demographic specific information, like what is the distribution between different races? What is the distribution between different gender identities and or age groups and so on, which is what we get from surveys, right? So the National Survey on Drug Use and Health focuses on substance use disorder and similar topics. Subpopulation specific estimates are available, which is an advantage relative to social media. And it's time consuming to collect and compile, which is a disadvantage relative to social media, right? So we wonder, since we have such a huge cohort, and we know that surveys have this, the NASDA survey has this benefit that it can do subpopulation level specific estimates. We were wondering, okay, can we try to run some NLP to see if we can estimate the distribution of gender identity and race and age group in our data? Obviously, we will not have it for everyone, but even if we have that information self-disclosed for a sample, can we then use that and compare it to what we find from the survey-based metrics? So that is what we did in this article we published in the Proceedings of the National Academy of Sciences using 288K cohort members. And I'll be honest with you, I was pleasantly surprised at how good the estimates were, or how close the estimates were to real life, especially in terms of race. You can see that NASDA is the orange one and Twitter is the blue one. And you can see that they are fairly nicely representative. And in most cases, there was they were within the confidence intervals of each other, right? When it came to gender identity, interestingly, you can see that for pain relievers or opioids, what we found was that, so first of all, I need to give a little bit of background on this. So one well-known fact is that in surveys about opioid use, the distribution of male and female is approximately equal. But when you look at overdose deaths, the distribution is 2/3 male, 1/3 female, right? And interestingly, when we did our social media-based estimates, although initially we were comparing with surveys, we found the Twitter estimates to be distributed by approximately 1/3, 2/3. And this is purely data-driven, right? We did not do any manual adjustment. And so we looked at the National Emergency Department visit data, and we found that the Twitter estimates are very close to actually emergency department visits, which makes sense. right? That more people are reporting non-medical use, more likely they're supposed to visit emergency departments. And so this, as you can tell, like is very promising because this means that we can potentially use social media to get much earlier insights about the distribution of substance use among different population groups, right? Um, the only subsets, or which I'm not showing here, which was messy, was age group, because social media has a skewed age group. So the age group distributions did not really match up. And that difference is explainable. Like we know that social media has a very skewed lower younger people, and as a result, it's likely that their reporting will be uh, more. So other things that we do, I also wanted to talk a little bit about some of the CDC works that we do. Another area where social media can be very useful is to look at um, people's perceptions or chatter associated with certain events, right? So when COVID started, our CDC collaborators were really worried about, especially from the Injury Prevention Center, that okay, now that COVID is starting and there are these stay-at-home orders in place, what is happening with people who are receiving treatment for opioid use disorder, right? And we found that the concerns of people during COVID, so you can see COVID, the comparator, before February 2020 or March 2020, there was never a mention of COVID, and then suddenly COVID went up relatively. And similarly, what we found that when we looked at opioid subreddits, we found that chatter about treatment and access also like jumped up. And then a lot of people were talking about treatment and access, and we did some analysis to find out why. And then there were several things. People were worried about losing access to treatment because of stay-at-home orders. A lot of people were worried about going to these facilities because, like, I don't know if you know how methadone clinics work. You have to go to the methadone clinic and then wait around to get your methadone dose. And a lot of people were worried that, okay, what if I go there and get COVID and things of that sort. And these concerns came up pretty naturally when we analyze social media data. And then we predicted that, this is bad because this means that it will probably impact overdose death rates. And we know now that during COVID, overdose death rates really went up. Other studies with the CDC, this from the NLP perspective, this is fairly straightforward because we were just looking at annual trends. Again, we know that from our subject matter experts, as I mentioned, that heroin, although heroin is the biggest or the most prevalent opioid, most commonly used opioid, it was decreasing in supply, and what is increasing is fentanyl. And when we analyzed temporal data over 5 years, we found exactly that trend. So you can see heroin tends to start off as 0.54, and then over time, the proportion of heroin-related chatter is decreasing. Fentanyl chatter over time is increasing, right? Although it starts from a very small number, but the increase is fairly rapid. And we are also now looking at polysubstance use. So we can even go and, because once after processing, we can look at individual subscribers on Reddit, and we can look at what drugs they're co-mentioning, and we have found that that is a very good, provides a very good estimate of what drugs are being co-ingested frequently, which is a big, like polysubstance use is a big area of focus now for NIDA because a lot of the deaths are being caused by polysubstance. Okay, my last study, and this is my favorite study, although NLP wise it is very not the most sophisticated study. However, so as I mentioned, that our work has more aspects of everything I've looked at so far. These are all public health studies, right? Looking at surveillance, looking at generating surveys or automating survey responses and things like that. At the same time, We also have studies that are more clinical in nature, and by clinical in nature, what I mean is that thankfully, I'm lucky to have a bunch of emergency medicine physician collaborators from all over the country now, from Philly, Rhode Island, Mount Sinai, Emory, now UCLA as well. And the way it works, our collaborations now work because now they have bought into the idea of social media. In the past, it took a while to get them to believe it. But now the collaboration. So the way it works is that they will see something in the emergency department which they cannot explain. Then they will come to us during our monthly meeting and they will say, hey, I saw this thing at the emergency department, or my patient at the emergency department mentioned tianeptine. Like, can you find out if tianeptine is a thing? Or as I was telling someone about it today, as like a collaborator from UCLA emailed us a few months ago where they were saying we have had a few visits of people who are on ketamine treatment. So ketamine is a drug that is used for treatment-resistant depression now. And they were like, they're using ketamine treatment, they've come in with severe stomach cramps. So is that a thing? Is ketamine, like, do you know if people on Reddit know? And of course, people on Reddit know. They call it cake cramps, and they have known it for years and years. So everything that you can think of, people on Reddit, because those are people with lived experiences, right? So they know they're the first sufferers, or they're the ones with the most knowledge. Now, this study, that brings me to this study. So a couple of years ago, my collaborator from UPenn, we were discussing in a meeting, and she told us that when people go into Philly, like the emergency medicine at Penn, which is like the hotspot for overdoses, what they do is they try to get them initiated on buprenorphine treatment, which is the treatment for opioid use disorder. And she was saying that she had observed a few people who have come in, when they initiate on buprenorphine treatment, they're having what they call precipitated withdrawal, which is a crazy form of withdrawal that happens if you have not abstained from opioid use for the certain number of hours. So basically the way treatment works is you do not take any heroin or fentanyl or anything for hours, and then you start your treatment and then you slowly settle on it. But people were having precipitated withdrawal even though they were claiming that they had not taken any opioid. And she asked us, like, can you find out on Reddit if that is a thing that is like common? And of course, yes, people on Reddit had been talking about precipitated withdrawal. They refer to it as PWD on Reddit. They had figured out the reason for these precipitated withdrawal. They had figured out that chronic users of fentanyl were having these withdrawals, and that was because although fentanyl is a short-acting opioid, it was dissolving in people's fat cells. It is lipophilic or whatever they call it. And as a result, people's fat cells were storing fentanyl. As a result, even if they abstained from opioid use, but they took buprenorphine, they were still having precipitated withdrawal. Now, not only that, they had figured out the reason, they had even figured out self-management strategies, and they had even given it a name called the Bernie's method. So they were teaching each other microdosing strategies by which they could avoid these precipitated withdrawals. And these are things that our doctors had no idea about. So we train, like, the doctors learned from these people with lived experiences, and this protocol was implemented at Penn Medicine, like this microdosing protocol. I don't know exactly, I should be careful about what I say because then, but the basic idea was the same, that, okay, instead of giving them a full dose of buprenorphine, start with microdosing while they continue to use their opioid, and it seemed to work. Now, this is something an email that I show with consent. I have consent to show this email. So after we publish this paper, one of the questions we get often is, do people on Reddit know that you're using their data? Is it ethical? Is it good? And so what I do is, in fact, one of our collaborators that I met in our meeting, we're the same place I met you, Meg, she told me about social licensing and ideas about social licensing. So I go on Reddit and I post whatever, when we publish a paper using their data, I go on the same subreddits and I post the papers, and then I talk to people. And once we published this, we started getting emails, and this is one of the best emails I ever got, one of the most, which is what makes me this study so fulfilling. So this person emailed the first author, who's my emergency medicine collaborator, and she wrote, thank you so much for publishing a scholarly article about the Bernie's method. It seems a lot of doctors, unfortunately, most doctors don't seem to know much about how fentanyl and Suboxone interact with each other. And then a junkie tries to tell them they're wrong and they get offended and just not helping at all. This is a very common scenario, you know? Imagine if I have a substance use disorder and I go to the doctor and the doctor's telling me do this and I'm like, no, actually, this is not the right thing, this is the right thing. Are they gonna listen to me? No, they're gonna dismiss me and then, anyway, so I want to thank you for doing the study because I genuinely feel like more people should know about it. A doctor recently told a friend of mine on Reddit that the Bernice method was not a thing. It should be a thing. So see, this is where, and we got a lot of messages on Reddit as well. So far from my experience, I have not had a single case where someone from Reddit said, hey, why are you using my data? So far, I've only had people who were like, thank you for publishing and giving this a voice. I get a lot of messages where they're like, the only angry messages I get are where people are like, why are you studying this and not this? This is more important than this, so you should write a paper on this. And I wish I could. Okay, to finish off, I want to give you some minutes, some time to question. I know I should talk a little about LLMs as well, because LLMs are the big things. So some of the things that we do is that we do a lot of studies where our medical experts, we curate social media data from Reddit for them, and then they go and do a thematic analysis where they review many posts, they identify common themes and things like that, or they have questions that they want to ask, and they go through each post to see what answer they get to those questions. So thanks to new age large language models and things like that, what we can do is, what we are trying to do now is to generate or take those questions from physicians and then directly generate the answers based on information provided on Reddit. Doesn't matter if the information is correct or incorrect, that's what the doctors do. There can be misinformation as well, but we want to know what Reddit says about a specific question. And then there are a lot of technical problems that come in. Like if you work with large language models, context window is limited, so you cannot just throw in the whole of Reddit and then ask it to summarize it, right? So more engineering type problem where what we do is we have a 2-layer architecture where we pass in like segmented posts or even full posts into the first layer, summarize them based on a specific question using a prompt. So these are the individual summaries. And then, I mean, it's pretty straightforward. Then we have another prompt, another question to summarize the individual summaries into a final bottom line summary. And we have gotten fairly, we have evaluated it manually. And we have actually evaluated not only large language models, we have also evaluated quantized LLMs. Because one of the things we are interested in seeing is that can we take very small LLMs, small LLMs. So yeah, small large language models and can, like those that can be run on personal computers, and then can we have them generate equally reliable answers. The benefit being then that then we don't have to run these questions for our doctors. Then we can just give them a software and say, install it and ask it all the questions you want to answer. And we found very good results. So with retrieval augmented generation, we can almost completely eliminate a hallucination. Interestingly, you know, like if you have done some prompting type research, you will see that at the beginning of prompting, the prompt always assigns a role to the language model. Like you are a medical expert or you're a radiologist or something. We found that when we tell the model to be a medical expert, it seems to have more creative freedom to state things that are not really accurate. However, when we prompt it to be a text summarizer, we specifically say you're a text summarizer, then it does not have that range of freedom, which was very interesting to see. And finally, I'll finish with this, I promise. So we are not only working with social media data in the substance use space, I'm also very interested in LLM alignment with human values in the context of like whatever I'm studying, whether it's violence or substance use or so stigma is a huge problem in substance use space, you know, like even in clinical notes, you will find a lot of stigmatizing language associated with people who use substances. And we have done research to show that like about 6 to 7 times, you're 6 to 7 times more likely to go for self-directed discharge if you have stigmatizing language in your notes, right? So now we are working on, okay, can we then with LLMs, like while LLMs are able to generate language fairly well, can we align them to be stigma informed so that they can generate non-stigmatizing equivalents to stigmatizing language, right? And so we're working on a framework where we have a supervised classifier that uses like one of those traditional encoder-only models like BERT, which can be fine-tuned to be very accurate in stigma detection. So what essentially it does is the supervised classifier detects if there is stigmatizing language or not, passes it to the large language model, which tries to destigmatize it using specific substitutions or whatever, and then it goes back to the supervised classifier to see if it is still stigmatizing or not. So it's like a feedback mechanism. We're using a supervised classifier, which is fine-tuned and specifically trained for a very narrow task, and we're using the supervised classifier to sort of monitor the large language model. And the only thing the supervised classifier focuses on is whether it's stigmatizing or not. And if it is, then it detects, goes back to the language model and comes back. We are working on this, so this is not some problem. If you solve it before us, then publish it before us or something. Okay, to finish off. Substance use and social media key takeaways. I've tried to focus more on the application areas. And also to show how to map NLP advances directly to tasks that need solving, right? So the question is not if social media should be leveraged, but how best to leverage it and what insights social media-based data can provide. Give a voice to underrepresented people in research with stigmatizing conditions. And that's not only substance use. There are a lot of conditions that are stigmatized. Mental health conditions are stigmatized. Violence, victims of violence are also often stigmatized. Domestic violence, intimate partner violence, where there is we have a long history of victim blaming, right? Early insights about emergent substances, that is one of the toughest problems we are trying to solve because it's easy once you know the name of a substance to go back and see, oh, people have been talking about it for 2 years, why didn't we look at it before? But it's very hard to know that substance before its name is known. And yeah, discovery of novel substances. And another thing we're working on is also on building more inclusive systems. So in the substance use space, women were excluded in research for a long time. Now they're included, but also non-binary populations are excluded from survey type metrics and things like that. So, and that is where we can use social media. If people are self-disclosing their gender identity, then we can, and we know that it's overdoses are probably more common among non-binary people, and overdose-related deaths can be a bigger problem. And so now we are actually building systems where we can not only estimate the distribution of binary gender identities, but also non-binary people. And with that, I'll end it. Thanks to all our funders and all our collaborators, and I don't really have any conflicts to do there. Thank you. Yes.
Yes. How do you deal with essentially fake or maliciously fake posts that might contradict some of these genuine posts? Like someone might say, you shouldn't microdose, you should macrodose or something.
Right, right. So on Twitter, for example, we have a bot detection system that works fairly well. Bot detection is fairly easy. We also added some features like lexical diversity and things like that because we found that bots don't really have much diversity in their expressions. So they're not very lexically diverse. Also like timing and things like that, bots don't sleep. They're posting all the time and things like that. So that way we substantially reduced bot activity, but there will be a few. What happens is when you have one or two posts that are sort of out of sync with the rest, they don't really affect the final outcome because the final one is always based on a larger chunk of data. So even with gender identity and those distribution estimates, it's not 100%. At the individual level, we cannot say, oh, we know this person's gender identity, we know this person's race. At the individual level, they can be incorrect. And that's why when I talk, I try to say that estimate the distribution of gender identities in this data rather than identifying gender identity. So there will always be some errors, but then the volume of data sort of masks if there are arbitrary noise information.
Follow-up question, what about if there's a foreign government hiring like 10,000 army of
That is,
like
yeah,
disruptive agents?
yeah, that may or may not have happened, right? Thankfully, we have not seen that in the substance use sphere. I mean, there is no financial motivation for them to do that in the substance use sphere, but I mean, we have
Just to disrupt the US society.
yeah, we have an election coming in less
Yeah,
than
exactly.
3 weeks, right? So we may see some bot activity in that space. But yeah, so in the substance use space, like we don't see that as a problem. And with Reddit is heavily moderated. So anything that you say that, so if you are talking about conspiracy theories, you have to go to the conspiracy theories subreddit to talk about conspiracy theories. If you talk about conspiracy theories in the COVID subreddit, and all the vaccine has, I don't know, microchip or whatever, they will ban you. They will not do a turn post and then they will ban you from that subreddit right away. So Reddit is actually, there are actually papers on the monetary value of all this free labor that all the moderators are providing on Reddit, and it's fantastic. It's in fact now I can go post some surveys on some opioid subreddits as well, and that's because I have tried to be friends with the moderators. I've tried to show that I engage with the community. So one of our xylazine recent studies I posted on the on opioid subreddits and directly allowed people to enter survey responses.
I'm curious, especially in regards to Twitter, did you do anything with emojis, like tweets featuring emojis or posts featuring emojis? How does that look on the technical side?
Yeah, I mean, explicitly, we have not done anything, but we do in our features, like when we do the text conversion to vectors, yes, emojis are there. Emojis are typically very useful if you're trying to do sentiment analysis or emotion analysis. We have a few papers in that space. We don't manually try to encode emojis, but typically, yes, if you have a smiley emoji, typically that is a good indication for either a positive sentiment post or a sarcastic post with a negative sentiment or something like that. So yes, emojis are great. They're especially for sentiment, emotion analysis and things like that.
I have one question. So do you do anything differently for the post that comes from anonymous account versus like known accounts? And do you think is it matter in the result?
We do not do anything separately. We just assume for Reddit, we assume everything is anonymous. We never look at the user name or the user ID in case there is anything identifiable. I don't really want to know, although it's public. So, but no, we don't differentiate between anonymous and non-anonymous account. Would there be a reason why you would want to do that? Or?
Yes, because I think if someone like post with his or her own account with actual name, they are more cautious about what they actually post. But when they are anonymous, they post like more blindly. You see, I don't. I think there are people with their own name do not share all of the thing that they want to. So
that is true. Yes, that is exactly why Reddit is so popular in the substance use topic, because people don't have to reveal their names. And in fact, I mean, we sort of assume that the substance use community is sort of far away from us. We have never met any of these people. That is not true. There are people, like if you look at those Reddit subreddits, you will see doctors, nurses, they will not reveal who they are, like their name, but they will say, I'm a nurse working in this place, and then I've been suffering from opioid use disorder for 6 years now, and no one at my work knows about this, or even some doctors and things like that. So it's, I mean, if there are 300 people dying every day from overdoses in the country, then you have to understand how widespread this is. So there's a book called Demon Copper. So there's a book called David Copperfield, which was written by Charles Dickens, right, many years ago. And the new American version of that is Demon Copperhead, which was published last year by, but it's like a 500-page book. And it talks about the opioid crisis in the US, how rural communities in the US were basically wiped out by big pharma and things like, so do you know what big pharma used to do? Like they would have sales people going there to rural communities, giving everyone a coupon for free 30 samples of OxyContin. Imagine, like they're just, oh, you have back pain, take this. You get free 30 OxyContin pills and you will never have to suffer, like there will be no side effects. And that's how there are entire communities that got addicted to opioids like this. Which is crazy. I read that book. Anyways, I don't know. I'm sort of moving, but yes. So being anonymous helps because it's people without being anonymous, they would probably not share all the stuff that they're sharing.
Yeah, like sorry, one last thing. Like I meant like if you only consider anonymous account instead of consider all of the accounts, for example in Twitter, maybe you get like more in to the point posted. This is my point.
That is very interesting and that is possible. We have not manually reviewed the accounts to see which account might be anonymous and which might not be. But that is an interesting point because anonymous accounts are likely to have more information available.
Yes. Exactly.
Yeah, we have not done that yet.
Okay, thank you. Very interesting topic.
Yes.
Can you repeat where the stigmatized EHRs come from and then who receives the destigmatized EHRs?
Yes, so that is something we are working on. So stigmatizing language EHRs, those are the doctors or nurses or service providers who are using the stigmatizing language. There are 3 types of stigmatizing language. There is stigmatizing labels like addict or junkie. There are doubt markers like where someone says patient claims to be in pain. So that is apparently a doubt marker where the doctor or whoever's writing it does not believe that the patient is in pain, but claims or things like that. And then there's scare codes where someone would say patient is in pain or like with under double quotation. So that's also a signal that it might not be true or that there is some doubt about. So those are encoded in the clinical notes of the patient. And then we analyze those notes in the military database to see with the stigmatizing language used within the cohort of people with opioid use disorder, and we looked at their outcomes, and then we found that, as I said, like about 6 to 7 times more chances of self-directed discharge if there is stigmatizing language in the notes. So what we are trying to work on is, have you used Grammarly? Yeah, so we are trying to have a product like Grammarly, or at least that's the envisioned goal, where this framework, or sorry, not this framework, this framework will basically connect to the EHR through an API, and as the doctor is writing the notes or typing the notes, it will basically underline stigmatizing expressions and then suggest edits.
So the doctor that's writing the stigmatizing note that's like sort of being suggested that what they're saying is stigmatizing?
Yes.
How confident are you that like telling them that they're stigmatizing will be enough to actually change their behavior or change patient outcomes?
I am not very confident. My medical collaborators are very confident because they say that there is an opportunity for micro-learning here. And often these stigmatizing examples or stigmatizing expressions are sort of a result of time constraints, according to them. So they say that it can be useful. And,
So it could be a micro interaction where you are learning with those suggestions how often you're doing it, where you're gonna get kind of these small reminders all the time, and that may help you realize how much you're doing this and then help you fix some of your behavioral small. These are all of these small iterations that actually can lead to big things, I guess.
Yeah, it takes time. So see, for example, when I wrote my first NIDA proposal, I was always using the term abuse, abuser. I was using drug abuser. And then later, it was much later that I learned that, okay, I'm not supposed to use these terms and language matters a lot. So, and then even now sometimes, and now in fact, one of the problems I have is when I'm talking about social media, you'll notice that I always say Reddit subscriber, I say Twitter subscriber and not Reddit user, Twitter user, because I was presenting to an addiction medicine community and I was using the term user, thinking about social media user, but they interpret it as that, oh, why are you calling people who use drugs users? That's a very bad way to refer to them. I'm like, no, I'm just talking about social media idiots. So yeah, it's often medical professionals themselves do not know that they are using stigmatizing language. It's often not voluntary. But yeah, there's probably some opportunity for micro-learning. And from the NLP perspective, I'm just interested in the alignment, that can we align LLM to use stigma-informed language?
So if you think of your visit, like they're talking to you and the doctor starts to say no. I think a doctor, so everybody's different, but if a doctor is kind of benign in this, they're typing their notes and they're getting signals that they're using, they see them doing that. I can see somebody getting up and facing the patient and changing some of the words that they're using. And that could change the reaction to the other. So I can see this in the setting. I actually have talked to a friend who's an African American who was talking about, I don't feel like I've had that experience. Maybe you're the white male that has not had that experience, but people of certain race or color, when you go to the doctor's office, she was telling me she doesn't like to go to the doctor because they don't treat her properly. And she didn't realize actually other people who look like you get treated properly. You say something, they listen to you. She goes and says something and they're like, they don't believe her, like, oh, you're just nagging or whatever. And she was talking about her experience as a general doctor's visit. And I realized how different a visit can be by how you look, because a doctor's treating you different. So when I saw this, I was like, that was reminding me of these conversations.
And it's not that doctors are terrible. We all have our own biases. And we don't even realize how our biases come across when we talk to people. And I'm sure if I was working in an emergency department setting, I would be trying to save lives all the time, and then there would be people finding me. I could easily get. I mean, I'm annoyed all the time, anyways. Anyway, so that's
Well, thank you. This was a great talk. I think we are at time.